Okay, hello to everybody. I'm very happy that we are all here today and celebrate the World Hearing Day. And I want to remind you that the World Hearing Day, being March 3rd, and the idea of World Hearing Day came from the IALP Audiology Committee years ago, when Professor Bu from China was a member, and he proposed, because March 3rd was the day of the ear in China, he said, if you take this date, we should propose it to the WHO, then you have 1/6 of the world population which have to celebrate it, but we are happy to celebrate it. And I'm very proud on our distinguished speaker we have today from our audiology committee of the International Association of Communication Science and Disorders. And we start with Christina Yoshinaga-Itano. Everybody knows her. She is a research professor and professor emeritus at the Institute of Coordinative Science at the University of Colorado in the United States, and one of the grand ladies in newborn hearing screening, the grand lady. So Christina, the floor is yours.
Thank you very much, Katrin. Hopefully you can now see my screen and can hear me clearly. So today what I'm going to be talking about is a recent study that we have completed on the long-term reading proficiency in an urban school district after the rollout of universal newborn hearing screening and our early hearing detection and intervention systems. So let's see. Hoping you can see this graph. I'm sorry, I'm moving the, I'm trying to get, okay. So this is a study that was published in 2012, and it's the mean reading grade equivalence from 1975 to 2003 for, and this is really from 8 years of age to 18 years of age. You can see the progression lines, but even if you look at just 18 years of age from 1974 to 2003, you see that the average reading levels of the children who were reported on the Stanford Achievement test were somewhere between 3rd and 4th grade levels. Now, I know that a lot of you have seen the many different research studies on different cohorts of deaf children. These children are very similar to the children that I'm going to be reporting on. 50% of these children were ethnic minority children, which is actually a lower proportion than the children that I'm going to be talking about. Also, 50% of the children were hard of hearing, and 50% of them were deaf children. So this is a very similar cohort to the one I'm talking about. What I want to talk to you in this graph, what you see is we began universal newborn hearing screening in 1992. And you can see that between 1992 and 1997, we only had about 20% of our population screened. By the time we were at the year 2000 and 2001, you can see that we were over 90% by 2001. Now, when we talk about 3rd graders, so I'm going to be reporting from the test years 2000 to 2013, 2014. That means that the children were born between 1992 and about 2006. So you can see that there are from 2000 to 2006, we have almost all of our population screened. So the children that I'm going to be talking about, in this particular school district, 71% of them are racial ethnic minority. 38% of them do not speak English in the home. And the critical key is that these are very at-risk children. 71% of them qualify for what we call free and reduced lunch, which means that they have food insufficiency. And the qualifications are 2 times what we call the poverty rate in the United States. Now, this particular population, since we began universal newborn hearing screening, we have had an average age of diagnosis of a median age of about 3 months. So in the time period we're talking about, particularly the years in which we were 90% or over, 88% of the diagnoses were made prior to 3 months of age, many of them by 1 to 2 months of age. And so we did, with the vast proportion of children, meet the 136. Now, again, this is an at-risk population, but our overall findings were that for each birth year, each additional class born during a period of universal newborn hearing screening, that there was increased reading proficiency in this school district of the children who are deaf and hard of hearing. In addition, in the year 2000, the children born before 1992, many children were judged to have too low language and reading proficiency, and they were exempted from the state examination. So you'll see that in 2000, only 17 of about 160 children actually took the standardized tests, whereas in 2013, 2014, almost the entire population, 165 to 171, took the examination. The other finding was that with each increasing grade, the children closed the proficiency gap. Now, what you'll see here are the pink, the yellow, and the green. The green are the children who are at age level or above age level. The yellow are the children who are partially proficient, but not quite at grade level. And the pink are the children who are unsatisfactory. And you can see that in 2000, the vast proportion of the children, almost 80%, were unsatisfactory, with only a very small percent in the satisfactory, proficient, or advanced range. By the time we get down to 2000, 2014, what you're seeing here is that it's basically almost 40% are proficient or advanced. And then there are another 25% of the children that are partially proficient, and about 30% of the children who are unsatisfactory. So the changes were from 18.8% to 68.5% for the partially proficient, and advanced children. The unsatisfactory decreased from 81.3% to 31.5%. And we did see slight changes in partially proficient, from 12.5 to 31.5%, but there was a big gain in the proficient to advanced from 6.3% to 37%. Now, if we break it down to the children who were not eligible for free and reduced lunch, these are children who were had no needs regarding food, right? The unsatisfactory reduced from 75% to 4.5%. And the proficient advanced increased from 0% to 70.5%. So this is a group that is not at risk in terms of socioeconomic. And this group, the vast proportion of them were at age level in the 2013-2014 testing. Now, when we look at the children who were eligible for free and reduced lunch, and that's almost all of it, 71% of them, the increases were significantly less, but they were significant. So they significantly got better for each birth year. and for each increasing grade. So it was not as dramatic. For the proficient advanced, it went from 8.3 to 24.8%. From the unsatisfactory, 83.3%, decreasing to 41.3%. So it decreased by half. We had children in English-speaking homes versus non-English-speaking homes. There was both groups made significant reading proficiency gains by birth year and by grade level. There were no significant differences between the two groups. And this just goes to show, you can just see that the green is increasing. The biggest change is that the unsatisfactory is decreasing. The biggest gains were in the partially proficient, but remember that for each grade level, the children are closing the gap and catching up. Now, we also had children who had hearing loss only versus children who had additional disabilities. Now, in this particular school district, they have what you call a primary disability. So these are children who were judged to have a primary disability of hearing loss, but they had another additional disability. So the children who are not represented are children with autism or severe intellectual disability, where the school district judges that their primary disability is not hearing loss, but their primary disability is autism or intellectual disability. Both the children with hearing loss and the children with these additional disabilities made significant gains by birth year and grade. There was no significant difference between the children with hearing loss only versus those with the primary disability, hearing loss, and an additional disability. Now, we also looked at the children who were unilateral versus bilateral. There was no significant difference between the bilateral mild moderate hearing loss group versus the unilateral hearing loss group. They made the same significant gains by birth year and by grade. However, the children with bilateral severe to profound hearing loss had significantly poorer reading proficiency than the bilateral mild moderate hearing loss or the unilateral hearing loss. However, all of the children, regardless of the degree of hearing loss, made significant gains by the birth year as well as by the grade. So one of the things that we have found with this particular cohort of children, remember that they are an at-risk population by socioeconomic status. There was no significant difference between the unilaterals and the bilateral mild moderate hearing loss children. And in previous research, we have also found that children with unilateral hearing loss who are in families with socioeconomic risk are at risk for developmental delays. So our summary is that these children should be considered for the same early intervention services as those that are provided for bilateral mild moderate hearing loss. So the key points that are really important to consider is that for at-risk populations, and who are we talking about? We're talking about, at least in the United States, are racially, ethnically diverse minority populations. We're talking about populations where there are lower levels of education of the parents. So these are including our immigrant and refugee populations from particularly coming from countries that have low and middle income. In the United States, we're talking about the children who are not in English-speaking homes, but are being tested in English in the school district. And in particular, these are children who are coming from families with significant economic challenges and food insufficiency. And one of the things that appears to be extremely important is that we meet EDDI 136 benchmarks, and that is to screen by 1 month, to identify the hearing loss by 3 months, and to enroll the children and families into early intervention therapeutic services by 6 months. We're also finding with other research conducted on our younger children that meeting 1, 2, 3, screening by 1 month, identifying by 2 months, and enrollment into early intervention services by 3 months benefits significantly the at-risk population with socioeconomic challenges. Thank you very much. Oh, I just wanted to acknowledge that the funding for this particular research was from the Centers for Disease Control through the Disability Research and Dissemination Center.
So, thank you so much, Christy. Are there questions from the audience? If
yes,
so, yeah.
Can I ask?
Sumaya. Yeah, Sumaya.
Yes, thank you, Dr. Itano, for your very interesting presentation, which is pertinent to our society where we have low income and low socioeconomic in our population. I would like to ask about the multiple disabilities versus with hearing loss versus hearing loss alone. It is interesting that there was no significant difference between the two groups regarding the reading proficiency. What is your explanation for this?
So these are children with what we would call milder secondary disabilities. So children maybe with a little bit, they might also have a language or speech disorder, or maybe a learning disability, but these were not children that have severe, profound secondary disabilities. So I think what it says is that they're getting additional service for the other special education needs, and it's working.
Yes. Do you have special recommendation for the intervention plan for this low socioeconomic, besides the hearing fitting and the speech therapy, special plan for this group who are low socioeconomic?
We do have a training plan for our early intervention providers. We provide our services in home language, and then we transition them from, we have a lot of children who don't speak English in the home, and then we transition them to English in the 2nd and 3rd year of life. By the time they're 5 years old, most of them are bilingually fluent in their home language and their and English. We also do a lot of instruction of our early intervention providers about cultural differences in the perspectives of disability, as well as decision makers in the home, and how that might be different from the primary dominant culture in the United States.
Okay, thank you very much. Thank you.
Yeah, thank you. One very short question from me, Christy. How can you be sure that the reading improvement is not also devoted to the Flynn effect? To the Flynn effect, yeah, which means increase of the intelligence.
I would say that I think that early intervention and higher language development, faster, better language development is affecting cognitive and intellectual development, and the children are doing better on their IQ tests. So but the thing is that actually these children many of them are in families where they didn't have the opportunity in their native countries for education. So they have, some of them are not literate. And we do have some of these families who are generational in the United States, and their families are not literate. But the children have gained from the public education. And because we have taught the parents how to do conversational turn taking very early in life, we have counteracted some of the negative influence of socioeconomics. So a lot of it is the training of the parents, but we can't ignore the fact that technology works better when we put it on earlier. So it's not just the early intervention. I mean, it's not just the identification. The identification opens the door for earlier and better intervention.
Okay, so thank you so much, Christy. It was wonderful as always. Now I want to give my presentation. About screening for congenital CMV, cytomegalovirus infections, and associated hearing loss. I got a funding by the Qatar National Research Fund because I speak about bi-national study. So congenital cytomegalovirus infections are a global problem. They are the leading cause of congenital infections and the most frequent non-genetic cause of childhood sensorineural hearing loss. They cause also neurodevelopmental delay, cerebral palsy, microcephaly, visual impairment, and more impairments, but hearing loss is the most striking and frequent one. The prevalence in Middle Europe, for example, is between 0.2 to 0.7, in North America 1 to 2, and in some low-income countries up to 1 to 5% even. This disease is globally underestimated because undetected. Nobody does, it's a long debate, but there are no national universal screenings for CMV infection so far implemented, to my knowledge. Only 10 to 15% of the infected babies are symptomatic after birth, but about 8 to 25% develop late onset symptoms, and in particular hearing and vision loss, but also vestibular symptoms. For the intervention, there are preventive measures during pregnancy to be recommended, and symptomatic treatment, for example, with hearing aids, and antiviral causal treatment. So if you see the situation in Germany, we have about 40 to 50% of the females, of the pregnant females, already infected without any symptoms. And a low proportion of them, 0.5 to 2%, transmits the virus to the baby. From the seronegative pregnants, 0.5 to 4% have a seroconversation, get infected during pregnancy, but 40% of them transmit the virus to the baby. What comes out is that estimated 1 to 2 per thousand, the same as for sensorineural hearing, for congenital hearing loss, the same number, develop during their youth, childhood, life, permanent symptoms. So it's a considerable problem. If you see the trajectories, this is from a Texas study, coming from a Texas study. You see the development of the head circumference of CMV infected children, which are in the lower range over the first 3 years. This is development of vision, and you see the asymptomatic Kaplan-Meier curves, and those who were symptomatic at birth. And you see that even up to the age of 16 years, about children who have been infected congenitally can develop first symptoms of vision loss. So this is such a child. She is 13 years old and has a scar, chorioretinal scar, found by age of 13 years. The same is the case with hearing loss. So here you see the course of symptomatic children and asymptomatic children. A large group of infected children, and you see that asymptomatic children can lead to a hearing loss first manifestation at age around 16, 17 years. These are the latest which are described. And what you see here is by age, first unilateral hearing loss becomes a bilateral hearing loss. And here you see that mild hearing loss becomes, the red are the profound hearing loss, develops to more and more severe hearing loss. 50% of the sensorineural hearing loss caused by CMV infections develop progressive or late onset hearing loss. 25% of all cases of hearing loss sensorineural at age 4 in the United States. And 40 to 58% develop severe or profound hearing loss. And it is the one kind of hearing loss, of sensorineural hearing loss, which is potentially causable, treatable. So it's worth to deal with it, to manage it. There is an international congenital CMV consensus recommendation group, which gave recommendations about prevention, screening, diagnostics, and treatment of CCMV infections in the Lancet Infectious Disease in 2017, based on a systematic literature review. And they said, considering several kinds of screenings for CCMV infections, that a universal screening of all newborns should be considered with a level 2B evidence. Studies, there are several studies. The one review of Cannon et al. I want to mention that universal newborn CCMV screening improves the long-term developmental outcome of infected newborns with late onset hearing loss. For diagnostics, a PCR of saliva or urine should be performed as soon as possible after birth, but at latest within the first 3 weeks of life. So this is our study. We screened more than 12,000 newborns, more than 6,000 from Germany, more than 6,000 from Qatar, with a buccal mucosal swab of liquid saliva, and performed a real-time polymerase chain reaction. Confirmation diagnostic was a second saliva sample and blood and urine PCR. If a CCMV infection was confirmed, we enrolled the babies in a follow-up program and wanted to gain information about the prevalence in both countries of CCMV infections, the feasibility and benefit of a universal screening of all newborns, and information about late onset manifestations of these infections, and wanted to develop a pediatric audiological, ophthalmological follow-up protocol of the infected children. The recommendation group said twice per year, children have to be go to follow-up examinations up to 3 years of age, and then once per year up to the year of 18 years, age of 18 years. I'm not very confident that adolescents would do that. Our results, we had CMV DNR in 38 babies from Germany and 15 from Qatar. An infection was confirmed in 18 German and 3 Qatari babies, but was likely in other babies. So our prevalence in Germany was 0.33%, as expected, a little bit lower in Qatar. The specificity of the screening was 99.7, which is excellent, or 99.9 even. We had also a control group where we performed a sensitivity study. It was 100% in our study. And these data fit well with those of Suresh Bopana, who made the first very big studies about this kind of screening. Positive predictive value and negative predictive values were fine as well. So we had 4 infected infants who were symptomatic. One child was symptomatic at birth. So this is a mandatory fail. That means it's not a merit of the screening that it was she was detected. One child from Qatar had a congenital hearing loss, but it was also detected by newborn hearing screening. This is another kind of screening which has been proposed, selective screening, only screening those children who fail a newborn hearing screening, but you will lose all those with late onset hearing loss. One child from Germany developed a late onset hearing loss and additional symptoms in the first year of life. So this was the real goal, or a target of our screening, so to say. And one child developed pathological findings on cerebral MRI. We need to follow up her for a longer time. The 3 children with clinical symptoms got antiviral, timely symptomatic treatment, treatment and timely treatment with hearing aids and additional rehabilitative measures. So 0.32 per 1,000 infants in our cohort showed typical symptoms of a CCMV infection. Screening identified 0.24 per 1,000 newborns who develop hidden or late onset symptoms and were treated in a timely manner, or who had hidden symptoms requiring further surveillance. To detect such infants early universal newborn CCMV screening seems advisable. And we found also a method where we could discern those who would be potentially false positive and those who would potentially correct positive hits by the amount of CMV DNR in the saliva swab. So I want to make it short. The recommendation group, who had no pediatric audiologist among them, said that asymptomatic named a CMV infection with an isolated sensorineural hearing loss asymptomatic, but with hearing loss, and did not recommend antiviral therapy routinely. But we argue to consider a hearing loss as asymptomatic contradicts everything what Christine, for example, told us just now about the outcome of such children, and the fact that progressive hearing loss is the most frequent sequelae of such an infection, and also the results of clinical studies where antiviral treatment improved or stabilized the hearing. So we shouldn't do that. My summary, is a universal screening recommendable? Probably yes. The feasibility is given and the validity, but we have to have in mind that most children, 75 to 80%, remain asymptomatic lifelong, and we need to find ways to consider the ethical and health economic questions, whether it is justified to trouble so many parents and to follow up so many children. Maybe there are some better solutions to educate the parents about first symptoms. It is still in the flow, and you need one who wants, or a country which wants to establish such a screening should found a national consensus group in order to agree on common strategies of the prevention, the screening, confirmation, diagnostic, follow-up, how often to test, what to test, the intervention, rehabilitation, public awareness has to be raised. National plans have to be elaborated. Cost-benefit analysis have been done several times. It's in the frame of newborn hearing screening a little bit more expensive. We should make sure that the Guthrie cards from metabolic newborn screening should be stored for checking them later whether infection was a congenital one. Propose it to the Ministry of Health, try to get pilot programs and do evaluations after a reasonable period. So thank you very much for your attention. Now I was a little bit long. Maybe there is one question for me from the audience. If not, then we have our next speaker.
Yes.
Yeah. Okay, I need
Yes,
to.
I have a question.
Yeah.
Yes, thank you for your very interesting presentation, because we have this problem in Egypt. If I encounter a child with a hearing loss that was stable over years, and by the age of 10 or 12 years, it becomes progressive. Do you think we should go ahead and do evaluation for the cytomegalovirus at this age, and it will help if it is positive to start antiviral treatment?
No, because you will not find out whether it was a congenital or postnatal infection. So therefore, I argued for the keeping of the Guthrie cards, which most of countries do the Guthrie tests with the blood, where you sometimes can find out whether there was an infection a congenital infection. But we did a study with cochlear implanted children, and we found half of children we treated with cochlear implants had positive CMV IgG, had an infection in former times, compared to the same age group with no hearing loss, who had a quarter of infected children. So it was double as much.
Okay, thank you.
Yeah, you're welcome, Sumaya. So our next speaker is Professor Mridula Sharma. I'm very happy to announce you, Mridula. She is director of the Master's Curriculum of Clinical Audiology of the Mackay University of Australia. I probably pronounce it wrong way. Mridula. You need to unmute yourself.
Thank you. Are you able to see my screen?
Yes, we can see it.
Beautiful. Okay. So here it's actually now 4th morning. So good morning, everyone. I thought what I would talk to you today is about the auditory processing disorders in children, and that when we are working with a child who has an auditory processing disorder, there is this highly likely that they would also show a cognitive and a reading, I guess, impact on their cognitive and reading aspects as well. And that needs to be considered when we are planning our intervention for the children. So that's what I'm going to really talk about and present some evidence that we have got, some published, some not yet. So first of all, when we're talking about the children, who are coming to us into the clinic, what are they coming for? What do they say to us? And this is in just last couple of years, we looked at 68 children and their families who had come to the clinic. And we looked at what is it that they actually highlighted as their concern. And if you see the last column, the blue one, and here basically the y-axis is the total number of reports. And the biggest thing that you note is the this blue column in the end is the aspect about concentration. That seemed to be the biggest problem. And the other one was being in noise. Now, we just clubbed everything that they spoke about when there were other people talking, when they were outside. So all of that has been clubbed together as noise. So the two factors that seem to be reported the most are listening in noise and being able to concentrate, sometimes in noise and sometimes not clearly in noise. And this is kind of consistent with what Shermack way back in 2002 highlighted when they had done their survey asking the pediatrician and the audiologist. So the question is, or the point is that nobody actually says they've got an auditory processing disorder. What they're talking about is, to them, there's a functional impact. That's what they're talking about. When we asked about the school, what were the reports from the school? Again, same children in their questionnaire, what they said was, we've highlighted some of these columns. Again, the y-axis is the total number of reports. And what pops up is, this red column, which is like everything. But what is this everything? It's basically listening. LI is listening, listening and concentrating, hearing and language. This is language, listening, and concentration. So once again, they're kind of talking about the listening literacy, language, or reading that seems to be highlighted for these children. So the common themes that are emerging here are basically children with suspected auditory processing disorder, or even if they are diagnosed. Some of the things that pop up are the concerns in reading, language, memory, attention, and the type of terminology that's used even in the studies, for example, is learning disorders, language learning disorders, listening disorders. So there seems to be, even in the history, the reference is to something beyond just auditory processing, which is and not just about hearing. So there's a lot of, I guess, a reference to for the children, not just from the schools, but even from the parents, and of course our own observation that it's not just about hearing. It is something more than hearing. It's more about, and it's more than just auditory processing as well. So, and just to highlight this, I thought I would show you this collection of some of the papers over the years who have said, well, actually, when you look at children with reading disorder, they don't have auditory processing. And these are just a few of those papers. Then there are these number of papers, including mine, where we said, no, children with reading disorders do have auditory processing disorders. And then there are a couple of papers that have said, actually, maybe it's not that every child with reading disorder, but maybe a subset of children have auditory processing disorder. And now it's 7 years old, but it's still a fairly good review of what are the types of auditory processing disorders that have been highlighted, provided proof or evidence for in children with reading disorders. So have a look at that if you're really interested in similar themes. And in a more recent 2019 paper, this is another subset of kids we saw, and we looked at children who only had reading problems as diagnosed by non-word reading deficits. And what we are showing over here is that the children had auditory processing, memory, visual attention, and combinations of these. There was like all children, all 25 children had more than one problem when it came to all of these. And this is consistent with what's been reported in a number of other papers prior to this as well. So it's a very strong I guess, evidence about for the reading and auditory processing connection. So the question is, of course, does that mean auditory processing causes word reading deficits? But actually what we've also noticed is, and that shows here as well, that the profiles are not consistent, that it's not that every child who has a non-word reading problem and therefore reading disorder has a memory problem or has a visual problem, but they're more likely to. So that means it's while there are these coexisting issues, it's not a consistent profile. So what is the profile? To do that, we decided to use cluster analysis. The advantage of cluster analysis is it's not anyone looking at the profiles and saying, oh yeah, this child has this, this, this. It's actually dumping everything, all the results we've got for all the children, you put it into the statistical package, and it then tells you whether there are common themes, common profiles. And that's what we were looking for. So this is a data set from 90 children, 7 to 13 years of age, and we looked at their auditory processing, reading, attention, nonverbal intelligence, memory, and we did the cluster analysis. Now, what this is trying to show is that we managed to get 4 groups, and each of these colors are different groups. And on the y-axis is the standardized scores on nonverbal intelligence. Here it's phonological awareness and memory. And basically that's separated my cluster 1 from cluster 3. And when I looked at non-word reading, then we had the cluster 2 and cluster 2 and 4 that got separated. In other words, there were, despite us thinking that every child is different, actually, based on just these 4 aspects, there are common profiles that were visible. But never believe only one study. But before I talk about another study, this is just to show, if you looked at those 4 profiles, what were their actual strengths? So group 1, what this is showing is that y-axis is standardized scores. So the lower, the more negative, the worse the performance. So here's one group which is really not very strong in pretty much everything other than auditory processing measure or frequency pattern test. And the others were, well, functioning similarly, but had some strengths in memory or nonverbal intelligence, non-word. So there are some strengths that we can work with. But as I said, never believe only one data set. Replication is something that is really required in our field. So here's another set we looked at, same thing. And what this is showing is 95 children who came to us with reading and listening concerns. And this basically, you've got a subset of children. On the y-axis, again, it's their non-word reading. So more negative is the worst performers. So there are some children here in the green color, really good readers, and then the red and the yellow ones, not so good readers. So when we looked at their cluster analysis, we found while the profiles were somewhat different, but the factors that separated them seemed to be very similar as what we found in ours. Here we have one data set where the kids are actually good at everything other than phonological awareness. But then you've got the other three groups who are not very good at everything, but there were some things that they were really poor at. So this was quite interesting. So once again, nonverbal intelligence, phonological awareness, memory, and word reading. And in this case, even frequency pattern test seemed to separate the four groups, which was quite reassuring. So what does this mean? Have I answered the question of causality? No, not really, but that's something we want to do next. But what we have, I think, established quite well is that this group is heterogeneous. This group does have more than their reading and their memory concerns that are very prominent. Attention, not really. That doesn't seem to segregate these groups. So the question now that we are looking at is, what is the main concern? Is there a causal relationship, or is it consequence of something else? So I'm not leaving you with an answer, but I am leaving you with a potential future research that we really need to work on. So thank you for listening, and happy to take any questions.
Very interesting, Mridula. Are there questions from the audience? Please unmute your microphone and ask. Honestly, I'm very happy to see this study or this bunch of studies, Mridula, because in Germany we have a S3 guideline on reading, on dyslexia, which sorted out auditory processing disorders from something which has to be considered and tested for. And I couldn't believe, but yeah, there are the other overwhelming evidences from your side, the other side.
Yes, can I ask?
Yeah,
yes.
Maya again, yeah.
I wish if I could join you, but you know, I have just come from the hospital. I was hospitalized with acute abdomen for 10 days, and that's why I couldn't join in the presentations. And I'm really enjoying your presentations, and thank you, Mridula, for your nice presentation. My question about, did you try, what is the profile of these children with auditory processing disorders and reading problems? Do they have certain profile in, if you do assessment for the auditory processing for them, or they are similar to the other children with, who are with visual problems or phonological problems? Do they have a specific profile?
You're asking a specific auditory processing profile, yes?
The reading
yeah, very good question. So no, actually, what we have done here is we've only looked at two types of assessments of auditory processing: the dichotic listening and frequency pattern test. Simply for the same reason that you're highlighting, because auditory processing, as you know, is such an umbrella term, right? It measures everything from your pinna all the way to cortex. So which measure is the right measure? So we started with just these two, but with the second study, which is the Gokula study, we did look at some other measures of auditory processing as well, and we didn't really find any strong profile other than the frequency discrimination and dichotic listening. So I think what's coming through for us are these tests. These are the two skills that seem to be more relevant when it comes to looking at kids with reading problems. So.
Thank you, and I would like to thank you for your comment that ABD is heterogeneous. It's very nice comment. Thank you.
So for the rest of the audience, Somaya Tafik from Cairo is also a member of our audiology committee of the IALP and has always a lot of questions, which is wonderful. So our next speaker, thank you so much, Mridula, is not Professor Rangasai, who has another meeting, but we posted some videos coming from him from India about issues of ear and hearing care. And now we have Riki, Dr. Riki Tatelbaum. She is senior researcher in the Communication Disorders Department of the Ariel University in Israel, and speaks about cochlear implants. Please, Riki. You just need to unmute.
Okay. Yeah. Just a minute. I will open it. Okay. Thank you, Katrin, and thank you, everybody. Welcome, everybody. I will talk today about cochlear implants, and I won't give one research, but I will give an overview. I see cochlear implant as all of us as a miracle of hearing, and I will take the next minutes. I want to take you on a journey that occurs throughout the time since the cochlear implant, the first cochlear implant, was launched. We will talk and give an overview about the history, the main trends that were developed over the years, CI users' achievements following this development, and the challenges that we still face, and the status of future directions. So I don't know who is the audience, but for those in the audience who are not familiar with cochlear implants, I'm not sure that there is one like this, but the cochlear implant is an electronic device with two separate parts, implantable electrodes and an internal magnet and an external speech processor connected by an external magnet. So we will start on the 70s of the 20th century. There were only single channel cochlear implants. Only one electrode was inserted into the cochlea. It provides electrical stimulation at a single site in the cochlea using a single electrode, as I said. Most cochlear implant users achieved better speech perception only with the aid of lip reading. Then the first NIH consensus was in 1988. There were already multi-channel cochlear implants for postlingually deaf adults. They were the first to be implanted, and only one out of each 20 CI users could understand conversation without lip reading. Back then, there were only around 3,000 implants throughout the world. The second NIH consensus was in 1995. Children with congenital deafness were added to meet the candidacy criteria, and postlingually adults achieved a mean of 80% in sentences identification via auditory modality. There were around 12,000 implants in the world. In 2008, there were many children and adults with bilateral cochlear implants. Gifford et al. Published a paper and findings for postlingually deaf adults indicated that most of them received 100% in sentences in quiet conditions, and there was a need for more challenging tests. At this time, there were already 120,000 cochlear implants in the world. And now, in 2021, there is growing number of candidates representing broad indications and around 800,000 implants in the world. So what were the main trends during these years? First, the evolution of technology. Second, changes in the aged implantation. And third, more audiologic indication. So we will start with the technology. What happened to technology? All over the year, there was developing new processing strategies for speech signal, changes in the electrode design, in length and in shape, straight or hugging the modulus, decreasing the processor size and cosmetic changes, connectivity. We know that many auditory inputs come from devices such as mobile phones, TV, etc. So for CI users, a connection to these devices via hearing assistive technology is a key component for improving hearing in many daily life situations. And last but not least, telefitting or remote programming that is very relevant to the current period with the COVID. So these were the main trends in technology. What about the aged implantation? There were two main trends over the years: decreasing the aged implantation for young infants from 2 years of age to 1.5 to 12 months, and now even 6 months of age and older, when there is a high degree of certainty regarding the hearing loss severity. This is very important. The second trend relates to the other side of the age range, implantation for older adults with no limits. And another issue that has changed over the years and created an increase in the CI population is implantation of children with multiple disabilities. As the experience with the implants grows and methods of mapping become objective like NRT and NRI, there was a possibility for implanting more complicated cases. What about the audiologic criteria? With the success of cochlear implant for children and adults with profound deafness who do not gain any functional hearing from hearing aids, the criteria were progressively broadened. And today, bilateral simultaneous cochlear implants for young infants become the preferred choice for infants with severe to profound hearing loss. An additional development is the option to consider CI for asymmetric hearing loss and for single-sided deafness. In order to achieve bilateral functions of binaural hearing, such as localization and spatial hearing in children with single-sided deafness, the implantation must be conducted during the first 4 years of life. So these are the main trends. And what are the achievements today with cochlear implants? So infants that are implanted at a young age develop very good speech and language abilities, and we compare them to normal hearing children. Many implanted children and adults demonstrate high speech perception achievements, especially under optimal conditions. But there is a wide variability in the performance, and many of them still have difficulties under noise conditions, but overall their quality of life improves significantly. So as a consequence of these achievements, many cochlear implant children are educated in mainstream education. There is better integration in society and workplace for adults, and older adults report feeling less lonely and less isolated and can take more active part in society. But there are still challenges. What are the challenges that we need to be resolved? So first, difficulties to perceive speech under adverse listening conditions, such as noise, compressed speech, many talkers. It is still an issue, although there was large improvement over the years. Many cochlear implants users cannot enjoy music as they used to, postlingual or for the first time for prelingual children. Why? Because some prosodic cues are not delivered efficiently by the device. Another issue is that the normal auditory system is using timing, frequency, and intensity cues in order to achieve binaural hearing. However, there is still a problem to deliver precise timing cues via the implants to achieve bilateral hearing based on these cues. And although many CI users achieve high speech perception abilities, they invest a lot of effort to achieve it. Listening effort defined as the mental exertion required to attend to and understand an auditory message. An individual with a cochlear implant may need more to rely more on cognitive resources such as working memory and attention to achieve comprehension. These may lead to fatigue and then reduce motivation of the cochlear implant user to participate in communication situations. So there are at least 3 methods to evaluate listening effort: behavioral, such as dual task or recall task, physiological methods such as pupillometry, and self-report questionnaires. Today, there is still no acceptable clinical measure to test it for listening effort and ways to decrease it with the implant. So we have more things to do. So what are the future directions? Future design will most likely improve neuronal health by reducing insertion trauma and improve techniques for hearing preservation. Improvements in speech recognition under difficult listening environments and music perception may be achieved through changes in the electrode neural interface or changing the method of stimulation. Another goal for many years is to achieve a fully implantable cochlear implant. Ultimately, future technologies will be integrated to allow tailoring of implant design to the individual patient, thereby addressing the broad variability in user performance. Thank you for your listening.
Yeah, thank you, Riki, for this very comprehensive and informative overview. It's always important, even if we are such professionals, to have this in mind, how it developed, how were the numbers, what are the challenges. Wonderful. So are there questions from the audience? I hope there are some. We still have 5 minutes for discussion. Questions? Yeah. Do we have some other issues to discuss still? And let me say one word about the World Report on Hearing, where some of us had the honor to be co-authors, reviewers, advisors. This report is really worth to be read. It has so many new information for all of us. There is so much evidence in it. So good a study of the literature about ear and hearing care. What can be done? How can hearing loss be prevented? What can be done to identify and diagnose it? What are the dangers and a new classification of hearing loss? So I really warmly recommend all of you to read this report. Yeah. Do the speakers have still something to add? No? If not, then I thank you all very much for your kind attention. I wish you a nice day, and those of you who want to attend other webinars, I announced some more, but there are a lot of events today regarding the World Hearing Day and the launch of the World Report on Hearing. Have a good afternoon. Bye-bye.
Thank you, Katrin.
Thank you.